So, and our final speaker, again, a colleague of mine, very, very pleased to introduce Christoph Mueller, who is going to talk about a sort of way of looking at medication exposures. We have a tendency when we're looking at medicines as an exposure in sort of big data to sort of group them rather arbitrarily by the type of disorder that they treat or where they exist in a formulary. And this is a kind of sort of way of looking at sort of properties of medicines across the formulary. And Christoph's going to sort of describe an approach in that area. Thanks, Christoph.
Oh, thank you very much, Rob. So I'll try to share basically, no, I think I managed to share the wrong desktop, did I?
No, we've got your slide. Oh, we just had your slides up just then.
The slide speaker view or the
well, we had some slides.
Yeah.
Just before you did whatever you just done.
Okay, let me try again. This is, yeah, I'm just so used to using Teams and not Zoom. So you can't see any slides at the moment.
Okay. I can't see your slides at the moment, but we had a glimpse of them just then. Do you want to just try once more?
So start share again. And now I basically want to share this desktop. And
that looks good. If just go to full view.
So is that now the full view of the slides? Okay,
thank you.
Thank you very much. So yes, so thank you for your introduction, Rob. So I'm going to talk about sedation-associated medications at dementia diagnosis, their receptor activity and association with adverse outcomes. And we're using data from a large clinical cohort assembled using natural language processing and data linkages. And we are basically using a dementia cohort, but we could actually virtually use any cohort of people with mental health problems being under a secondary care provider. We just started first with dementia because people with dementia have a very specific time point at which they receive this diagnosis and where there are lots of data is actually recorded around those patients, which gives us a very good time point for follow-up. The problem we wanted to address, and Rob has briefly mentioned it, medications with sedative properties are considered problematic, but actually they haven't received much research attention. So I guess there is some research on maybe benzodiazepines being bad, kind of as being associated with higher mortality, being associated, being associated with more hospital admissions, for example. But there's no cross-property research. So most studies on the adverse effects of medications are actually by therapeutic indications. So we are researching, are antidepressants bad, are antipsychotics bad, are benzodiazepines bad, are sleep medications bad, but rarely across cross-category properties that are examined, like, for example, does that medication induce drowsiness? One example that has been studied quite a lot in dementia are anticholinergic medications, where one line of work goes really, if I review anticholinergic medications and reduce anticholinergic medications, can I reduce the dementia evidence? The work we've been doing was more in people who already were on those medications in dementia, and we could, for example, show if you take all medications with anticholinergic properties going into the brain, there's a higher risk of mortality and emergency hospitalization, and those people spending more time in hospital. When we looked at specifically antidepressants or antipsychotics, anticholinergic properties didn't seem to play so much of a role in relation to mortality, hospitalization. So that doesn't seem to be the main effect that causes problems in those medication groups. But when we looked at bladder drugs, so in people with dementia, those with a high central anticholinergic potential were both related with a higher risk of mortality and a higher central anticholinergic burden. And those drugs are not necessarily or least likely to be prescribed for a symptom or a neuropsychiatric symptom of dementia. So that shows basically that there is something about the cholinergic hypothesis in dementia. For all this research, we use the clinical record interactive search system, which Guyan has already explained in much detail. So I'm not going to go into too much detail again. So we're using the clinical records from mental health patients in Southeast London. And actually to access those records, we need natural language processing, because I guess we as psychiatrists, we just tend to write a lot into the records, and also we often, and unless prodded a lot, we tend to ignore structured fields in the health record. And I was particularly interested, or we were particularly interested in this study in natural language processing to identify medications. So how do we actually identify medications that are only recorded in kind of free text? So you develop your NLP, which is developed through expert annotations, so that some documents get flagged up, which might contain medications, and domain experts code whether the variable of interest is present in the current document, having or sometimes not having predefined coding rules. We want to ascertain positive mentions of those medications, and kind of we want to know those medications are there. So it's not about negation statements or kind of statements of uncertainty. Those are more often kind of classified as this medication not being present. Like we wouldn't look for statements not on any antipsychotic, for example. So those natural language processing softwares are always geared kind of towards precision, positive predictive value, making sure that what you pick up is really there. But then, of course, you have less sensitivity. And if it's not there, you can't be 100% sure that it's really not there. Further, a gazetteer is used, which contains labels all instances of medications from the British National Formulary, and we also have a list of potential misspellings. The gazetteer also identifies time and route of administration. This natural language processing wants to identify current use. I guess it's no use to us if that patient has been on a certain medication we want to research in the past. So it looks basically where something is saying about current use, either a dose information, or it's a plan, a current medication, or it says prescribed, or it's somehow discernible through inference, like saying patient is faring better on a certain medication. We supplemented with data from structured fields and also from pharmacy records, but that's really only like 20% of the data we are getting from there. So the NLP is actually very important. So positive examples, the NLP would pick up a certain medication if it, for example, says plan to restart the medication today and written a script, or plan to continue this medication, or at present the patient is currently on this medication. And negative examples where basically the app would say, no, no medication is mentioned there. So it would basically say history of poor compliance with medications, has been on those medications in the past, or referred by the emergency department following taking an overdose of a certain medication, or we just gave this patient a leaflet on the medication. But for us, we actually don't know, do they actually take this medication? Going now to kind of those sedatives as cross-category property of medications. So as sedatives, we defined all medication that had drowsiness as a potential side effect in the British National Formulary. So that was any medication, any sedative was any medication, the BNF, that had drowsiness mentioned as a side effect. And then we went into a bit more detail. We looked at medications who had drowsiness as a side effect, as a common and very common side effect, and an indicator of strong sedation. So we had predefined some indicators of strong sedation, which would be a cautionary or advisory label for drowsiness in the BNF. For antipsychotics, we could go to the Maudsley prescribing guidelines, and then where the sedation caused by those medications is rated. And for anticholinergic drugs, we had the aforementioned anticholinergic effect on cognition scale, where we again could see is the sedation or the anticholinergic effect, the sedation due to that anticholinergic effect strong. So this was our amber group, our red group. In our amber group, they had also common drowsiness as a common or very common side effects, but there was no indicator of strong sedation. And then the other medications in the yellow group, sedation was uncommon or very rare or very rare at the BNF. We went a little bit further and also looked in the common and very common group, also red and amber, also at receptor actions, and looked at certain receptors on which this medication acts according to drug base from Canada. We looked at the half-life of the medication, if that played a role, and grouped it into under 12 hours, 12 to 24 hours, or more than 24 hours. And we looked at the indication for which that sedative was prescribed. Was it a non-psychotropic sedative? Was it a psychotropic sedative? Or maybe were those patients on both psychotropic and non-psychotropic sedatives at the same time as exposure groups. For our outcome, of course, the data we get from the clinical record interactive search system, but for our outcomes, we use linked data for hospitalization to hospital episode statistics from NHS Digital, and for death certificates, we use a linkage to ONS death certificates, where we are, for our study, of course, we are only interested in the date, did they die or not? And for hospital episode statistics, we were only interested were they admitted or not to hospital, and at what date in relation to the index date. We adjusted for a wide range of covariates to account for, of course, demographics, mental health symptoms, physical functional problems, as well as certain medications prescribed we thought would play a role in this pathway, as and similarly to what Gayan has mentioned, how those are certain. So, and coming to our results, we identified 15,000 patients with dementia. 1/3 of them was not prescribed any sedative medication at that index date of them receiving their diagnosis, and 2/3 were, whereby the majority was prescribed sedatives which had common sedation and strong sedation, or half of them roughly, and the other half had still sedatives that have common, very common sedation, but there was no indicator of that being very strong. And 612, a very small number only, were prescribed sedatives that patients that had drowsiness mentioned as rare or uncommon in the BNF. And so those are some of our exposure groups, any sedatives, and then the red, amber, and yellow. We also looked in now only red, amber at the receptor action, and you see basically it's pretty much almost evenly distributed. Most common are antihistamines in terms of sedative effects. Very uncommon are alpha-2 agonists in our population, and NMDA antagonists, which are actually anti-dementia medications, are somewhere in the middle. Half-life, you see most common is actually a long half-life, and that's also because if a patient was on several medications, we classified them according to the medication with the longest half-life. And for the analysis, the comparison group will be again the no sedative group. So we compare alpha-1 blockers to patients on alpha-1 blockers to patients on no sedative. And lastly, we looked at the prescribing indications, so non-psychotropic sedatives, psychotropic sedatives, and being on both psychotropic and non-psychotropic sedatives at the same time. And each of those compared again to no sedatives. So moving on to results, what we found is basically being on any sedative didn't predict mortality, but it predicted hospitalization. And when talking about hospitalization, there didn't seem to be any difference if the sedation was frequent, not frequent, strong or not strong. So being on any sedative just is associated with a higher hospitalization risk. While when we come to mortality, actually only those who had medications with very common sedation and strong sedation was associated with a higher mortality risk. Interestingly, those with a very common sedation that wasn't classified as strong also had a slightly lower mortality risk, but it's really almost not significant, but it is something to think about. When looking at the specific receptors, so those on GABA agonists had probably the most adverse profile. So those were both associated with a higher mortality and a higher hospitalization risk, where we couldn't find anything specific for the other receptors involved in kind of causing drowsiness, other than also that NMDA antagonists were associated with a higher hospitalization risk. Interestingly, in half-life, similarly with the frequency of sedation or the strength, that didn't really affect hospitalization. So at least just being on any sedative medication poses a hospitalization risk. But with mortality, we found that largely those on purely medications with a short half-life were at a higher risk of mortality. And lastly, when we come to the prescribing indications, those with psychotropic medications only were at a higher mortality risk, while non-psychotropic sedatives were more related with a higher hospitalization risk. So summarizing this, so receipt of any sedative increased the risk of emergency hospitalization, but not mortality. And then emergency hospitalization, that seemed to be just something that was almost applicable to any of the subgroups we examined, aside from the receptors. Common and strong sedation increased both the risk of mortality and emergency hospitalization. When we come to receptors, I think the most adverse risk factor, adverse risk profile was in relation to GABA agonism. And of course, those are benzodiazepines, Z drugs. And of course, those medications are associated with serious side effects if used for a longer period of time, like tolerance, dependence, increased risk of falls, fractures, and even impaired cognition. Interestingly, medications with a shorter half-life were associated with an increased mortality risk. And of course, that could be, on the one hand, those medications work very quickly, so the patient becomes sedated very quickly, which could already pose some issues. And then they were also off very quickly and might also for that have higher potential for dependence, for example. On the other hand, medications with a short half-life are, of course, preferably prescribed for people who already have some additional illness. So they are often prescribed for people with comorbidities like hepatic impairment or impaired renal clearance. So despite us trying to adjust for a number of covariates, there might still be some bias by indication for this. I mean, those NMDA antagonists were associated with an increased hospitalization risk. And if we go to psychotropic sedatives, of course, we know that most psychotropics are associated with a higher mortality risk, whereby we, of course, cannot necessarily disentangle. Is that the illness or is that the medication themselves? Just for people in dementia, we just are very cautious about the hazards in relation to antipsychotic medications. Interestingly, non-psychotropic sedatives were associated with an increased hospitalization risks, but I guess those people are just maybe also more severely ill, and then they are prescribed a medication for one of those physical health conditions where the clinician might not necessarily be aware that they are that sedative. Just in terms of discussions, this is formulary data, so it's not a direct measure of sedative properties. When it comes to half-life of medication, we need to be aware that some medications, of course, have an active metabolite, which makes the kind of classification of half-lives a bit more tricky. We try to account for this, but it might not have been perfect. But such tools to review those medications or being aware of those cross-category properties gives us opportunities for medication switches, because there might be, for example, if someone is prescribed a medication for migraine, there might be an option to change this to a different medication for migraine that is less sedative. But we can't find differing hazards in subgroups according to frequency, severity, receptor action, or half-life or prescribing indication. So you see it is all quite complex, and this complexity is kind of likely to overwhelm everyday clinical practice. So if a clinician really needs to think about all of those things, you can't really do this in a very short clinic slot. So, and that just re-emphasizes the need for decision support tools to have a more personalized approach towards mental health care. And this is just, MediCheck is just one of the examples which we have developed with Mindwave Ventures, which is freely available. And you can just basically add the medication the person is on. And it was initially developed for anticholinergic effects, AEC, but it will now also talk about sedative properties in the drowsiness column. And very lastly, thank you to the team. There's a large team involved in this piece of work, and thank you for listening.